Welcome to OPPS webinar on the OPPS proposed rule and the IPPS final rule. Today you will be hearing from our public policy team, which includes myself, Susana Molina, Aaron Badita, Sherry Danielson, and Marisa Lopez. The first section of this webinar is dedicated to the IPPS final rule. As a reminder, the IPPS sets the reimbursement rate for inpatient payments and stipulates changes to the hospital quality programs. The policies implemented in this rule, unless otherwise mentioned, become effective on October 1st of 2019. The rule also includes updates to several of Medicare quality programs, including the Inpatient Quality Reporting Program, Hospital Acquired Conditions, the Hospital Readmissions Program, Value-Based Purchasing, and Promoting Interoperability. This slide provides an overview of the issues that our team will be covering in today's webinar. In this year's rule, CMS increased the market basket update for inpatient hospital payments by 3% or $3.9 billion. They're establishing an ACA productivity cut of 0.5%. Operating payments will increase by 2.9% or $2.9 billion. DISH payments will encompass a total of $8.35 billion, which is a $78 million increase compared to fiscal year 2019. There will also be a macro documentation and coding adjustment of 0.5% and a capital payment rate update of 1.4% or $100 million. The most significant policy in this year's IPPS rule pertains to the hospital wage index. The wage index captures the cost of labor in different states. So the higher the wage index a hospital has, the higher the inpatient payments that hospital will receive. Therefore, if a hospital is located in a state such as California or New York, where the cost of labor is higher, inpatient payments will be higher as well. The data used to calculate the wage index comes from labor costs reported in a hospital's cost report, specifically worksheet S3. And CMS uses 4 years of historical data to make that calculation of the hospital wage index. In response to the rise of hospital closures in rural areas, CMS proposed in the IPPS rule changes to improve the wage index for rural hospitals and increase their payments. Specifically, CMS proposed to increase the wage index for hospitals whose wage index is below the 25th percentile by 1/2 the difference between the hospital's wage index and the 25th percentile wage index. Because CMS wanted to make this policy budget neutral, they proposed to fund this increase in the wage index for rural hospitals by lowering the wage index by 4.3% for hospitals whose wage index is above the 75th percentile. So mostly urban hospitals where the wage index tends to be higher. CMS finalized this policy, but with one modification. Instead of lowering the wage index for all hospitals whose wage index is above the 75th percentile, CMS will instead adopt a 0.2% payment reduction for all IPPS hospitals across the nation. To mitigate the impact of this change, CMS will also institute a 5% cap on any decrease to a hospital's wage index compared to fiscal year 2019. This policy will be effective for only 4 years, from fiscal year 2020 to fiscal year 2024. According to CMS, this will give rural hospitals sufficient time to raise the wages of their employees using the newly increased IPPS payments. Because the wage index is calculated using 4 years of historical data, CMS assumes that in fiscal year 2024, the hospital wage index for rural hospitals will be higher, and therefore they will no longer need to continue this policy. Another issue that CMS seeks to address in the rule pertains to the reclassification of urban hospitals to rural. Currently, states can achieve higher inpatient payments for their hospitals by encouraging the reclassification of urban hospitals to rural. And this is how that issue plays out. So currently, the statute states that the wage index for urban hospitals cannot be lower than the wage index for rural hospitals. The rationale is that the cost of labor in urban areas is higher, so urban hospitals should always have a higher wage index. What happens is that when an urban hospital reclassifies to rural, the higher wages of that urban hospital cause the wage index of all rural hospitals to increase. When you apply the statute, urban hospitals with a wage index value below the rural wage index will see an increase in their wage index, even though those urban hospitals never truly increase the wages for their employees. To address this issue, CMS is finalizing the policy to exclude the wage data of reclassified rural hospitals from the rural floor calculation. That way, even if an urban hospital reclassifies to rural, that will not affect the calculation of an urban hospital's wage index. They will not have increased inpatient payments as a result of that change. Now moving on to Medicare add-on payments. Medicare add-on payments are additional payments that CMS provides to incentivize the use of new technology for Medicare beneficiaries. These add-on payments are only provided for technologies that have already been approved by CMS, so not all technologies are eligible for additional payments from Medicare. In this rule, CMS is increasing the add-on payments for new technologies from 50% to 65% of the technology price. So if a technology costs $10,000, the hospital will receive an additional payment of $6,500 to capture the additional cost of using that technology. Those add-on payments will also be applied for CAR-T therapy, which is about 2-year-old therapy that is used to treat cancer, resulting in an increase for that therapy from $186,000 to $242,000 per case. These are the new add-on payments that CMS is finalizing for fiscal year 2020. And these are the additional add-on payments that CMS finalized in the past and will continue to provide for the outlined technologies.
Disproportionate share hospitals receive federal funding in the form of DISH payments to help offset their financial losses that these hospitals incur because they see a larger share of uninsured patients than their peers. A hospital's DISH payment is a percentage add-on to its base DRG payment and has historically been calculated using, among many other factors, 3 years of worksheet S10 data. In this rule, CMS finalized an $8.35 billion DISH payment for fiscal year 2020. The reduction that you see on the slide from the previous amount, the proposed amount, is due to a change in the Factor 1 input. Feel free to reach out to our team if you would like to know more about the calculation change. We're happy to provide those numbers for that factor. CMS will also now use a single year of worksheet S10 data. CMS received feedback that mixing multiple years of audited and unaudited data in the past can skew the results. So because of this, CMS is opting to use just 1 year of fiscal year 2015 audited data. Although CMS is making this change, they caution us that they will consider returning to use of a 3-year average if just 1 year of data proves to have too much viability.
Now moving on to graduate medical education. CMS proposed a rule that would allow residents from a teaching hospital to rotate through a critical access hospital. Hospitals will receive lower payments from CMS for their GME program if their resident FTE count is under their cap amount. By changing the definition of a non-provider site, teaching hospitals will be able to count these residents as their FTEs as long as they continue to pay their salaries and fringe benefits. OPPS supported this proposal because this change could help alleviate some of the provider shortages in many areas, and CMS ultimately finalized it. Now moving on to quality programs. As a quick refresher, there are two types of quality programs within Medicare, mandatory and pay-for-performance. For the mandatory reporting programs, although hospitals are required to participate, payments are not affected by how a hospital performs in these quality measures. For the pay-for-performance programs, hospital payments can be reduced, or in the case of VPP, increased depending on how well the hospital performs. Now it's the hospital inpatient quality reporting program. Under the IQR program, CMS collects quality data to improve quality, cost, and transparency by publicly displaying data to help consumers make more informed decisions about their healthcare. CMS finalized 2 out of the 3 proposed measures to be included in the program. The first finalized is the safe use of opioids concurrent prescribing measure. It will be adopted for the calendar year 2021 reporting period. The second measure finalized is a hybrid hospital-wide all-cause readmission measure. This measure is proposed to be adopted in place of the claims-based hospital-wide all-cause readmission measure. CMS plans to transition it in. The hybrid measure will be voluntary for the first 2 reporting periods. On July 1st of 2023, this measure will be made mandatory and the claims-based measure will be removed. The hybrid measure differs from the claims-based measure in that it incorporates both claims data as well as clinical data elements pulled from the EHR. The claims-based measure only uses claims data. The measure not finalized was the hospital harm opioid-related adverse events measure. Many commoners, including OPPA, expressed concern with this measure because of the potential unintended consequences of disincentivizing clinically appropriate treatment. For this reason, CMS will not be including it in the IQR program. Moving on to the hospital readmission reduction program. This program is a Medicare pay-for-performance program that reduces payments to hospitals with excess readmissions. The 8 measure removal factors that are currently used in the IQR and VPP program were adopted for HRRP. Again, no measures were proposed to be removed at this time. Also finalized was a modification to the definition of dual eligible to exclude those that die in the month charge from the overall readmission count. Many commenters believe that this update will more accurately reflect a hospital's dual eligible population and improve data reliability. CMS anticipates about a very small 0.2% increase in dual eligible stays due to the definition modification based on the fiscal year 2019 performance period.
The Hospital Acquired Conditions Program, or the HAC program, is a pay-for-performance program, and this program accounts for 1% of that total 6% potential penalty that a hospital can incur. It works by reducing the total payments for the bottom quartile of hospitals. In the HAC program, one score is the overall average of each measure. You may remember from last year that each domain is now scored with the same weight. CMS did not finalize any changes to the measures included or the scoring approach for the HAC program this year. CMS did, however, finalize inclusion of the same 8 measure removal factors that we see being adopted across quality programs in both the outpatient and inpatient rules beginning in 2020. CMS cited OPPA's recommendation to standardize all removal factors across quality programs as one reason that they move ahead with this change. As a reminder, none of these factors equate to an automatic measure removal. They really just provide us with a lens through which CMS evaluates measures' relevance. The VPP program, the Value-Based Purchasing Program, is also considered a pay-for-performance program. However, this is the program that functions a bit differently. VBP is the only quality program where hospitals can earn an incentive payment for good performance. The top performers can gain up to 2% in incentives, but because this is a budget-neutral policy, it means that the bottom performers are also at risk for a 2% penalty. VBP pulls measures from IQR, the Inpatient Quality Reporting Program, so we always look at IQR as a menu for what could be in VBP. VBP continues to be comprised of 4 domains: efficiency and cost reduction, safety, patient and caregiver experience, and clinical outcomes. CMS is not changing these weights in any way. They will continue to be at 25% for the next year. CMS is also not proposing to add or remove any measures from the VBP program for fiscal year 2020. We'll shift now to take a look at the Promoting Interoperability Program. You may have known this as a Meaningful Use Programs or the EHR Incentive Program. This is a mandatory reporting program, meaning there's no payment penalty or incentive associated, but you must participate. CMS has finalized some changes to the PI program this year. They are looking at changing reporting requirements and measures this year, and also requesting comment on potential new measures to include in the future. CMS will continue its 90-day reporting period for hospitals and critical access hospitals for calendar year 2021. We saw this introduced in the last IPPS rule for 2019 and 2020, so this is just extending that change to another year. In addition, all numerators and denominators for measures will now be based on actions that have occurred during the reporting period, with the exception of the security risk analysis. We advocated for this change here at OPPA as we believe it will help to reduce confusion around measure implementation. CMS has also finalized changes to the measures and scoring, and these both center around the fairly new opioid-related measures that are highlighted on the slide. First, the query of the PDMP measure will now be voluntary. You will still be able to earn bonus points. This measure will also convert to a yes-no attestation instead of being calculated as a numerator and denominator as it was in the past. Originally, this measure was going to become mandatory in 2020, but we supported this change, and we recommend that CMS continues to work with the ONC to support EHR integration of the PDMP, and they agreed to do this. Second, the Verify Opioid Treatment Agreement measure is going to be removed completely. CMS does not believe that this measure is particularly meaningful the way that it's currently structured, and they receive feedback from numerous hospitals and health systems that it is creating undue burden. So with these changes, this is how the new scoring methodology will work. You'll see it on the furthest right column on the slide. The points that were originally allocated for those 2 opioid-related measures will be absorbed by e-prescribing and provide patients electronic access. The total points at the bottom will still be 100, and we have the opportunity to earn 5 bonus points for the PDMP measure.
Okay, and before we move on to the OPPS proposed rule, you may use the chat to input any questions that you may have about the policies finalized in this IPPS rule. Okay, seems no questions right now. So moving on to the OPPS rule. This rule sets the reimbursement rates for Medicare outpatient payments, including payments for ambulatory surgical center procedures. Comments to CMS are due on September 27th. Our team is currently working with stakeholders across the different healthcare systems to develop a response for CMS. If you have any questions or thoughts related to the proposals discussed today, please let us know and we will do our best to incorporate your comments. The final rule is expected to be released in November, so some of the policies included in the rule may change depending on CMS's response to provider feedback. This slide provides an overview of the issues that we'll be covering in this presentation. I want to highlight price transparency and changes to the 340B program, as these were the 2 most significant issues that were included in the OPPS rule. The changes proposed for these issues also reflect the priorities of the current Trump administration. CMS is increasing OPPS payments by a net of 2.7% or $6 billion. They're also increasing ASC payments by 2.7% or $4.89 billion. For the OPPS payment increase, this has been the biggest increase that CMS has granted for OPPS payments in the last couple of years. There's also a market basket update of 3.2% or $6 billion, and ASCs will also see an increase of 3.2% or $4.89 billion.
Now moving on to price transparency. This has been a significant priority area for the Trump administration. In last year's rule, CMS mandated that hospitals post their charge master in a machine-readable format, as well as release a request for more information on how price transparency could be implemented in hospitals. Seema Verma has also been quoted on saying that this move was the first step, so we have anticipated that there is more to come. This past June, President Trump issued an executive order for providers and insurers to post their negotiated rates, and the proposal is really the implementation of this order. The proposal will require hospitals to post charges for 300 shoppable services. CMS defines a shoppable service as a service package that can be scheduled by a healthcare consumer in advance. These include services that are typically routine or provided in non-urgent situations and do not require immediate attention to a patient. 70 services are chosen by CMS to ensure standardization across hospitals. The other 230 services can be chosen by hospitals so that they can tailor their services based on their patient demand. Hospitals that do not comply will be faced with a civil monetary penalty of $300 per day. For each of the 300 shoppable services, hospitals will need to post the following items. The biggest takeaway from this list is that hospitals will now have to post their payer-specific negotiated rates. This is an unprecedented move, as no other industry has been mandated to release their prices negotiated under contract. While CMS believes that publicly posting this pricing information will increase competition and lower costs, some industry analysts are not quite sure of the actual impact this policy will have. Additionally, these charges must be displayed prominently on a website for patients to find in order to be in compliance. Also, CMS is considering on using an application programming interface to post charges to assist with the development of future technologies for price transparency. APIs can enable software developers to more easily create programs without needing to know the internal workings of provider software and patient data. As we develop OPPS comments to CMS, we have a few considerations to help frame our response. One consideration is if the negotiated rates are even helpful to patients, as that's not usually what they pay out of pocket, and if it's not helpful, what type of information would be best to provide to them. We also want to strongly consider the economic impact it'll have on healthcare. Some analysts believe that unveiling the negotiated rates will allow some hospitals to work together to raise prices and not encouraging the competition that CMS is aiming for. As we continue to see this issue evolve, we anticipate more conversations around how quality information will be integrated with pricing. Since the aim of price transparency is to improve the value of healthcare, knowing the quality of care that hospitals or doctors provide is an essential element to this. Patients can easily conflate cost with quality, which may lead them to choose higher cost of care even though it may not be the best quality. This would somewhat defeat the purpose of what price transparency is trying to achieve. Seema Verma recently echoed this in one of her statements. She said, "Price is only part of the equation. Just as important is empowering patients to understand healthcare quality." This leads us to believe that CMS may easily try to integrate quality into future price transparency proposals.
Transitioning now to the 340B drug program. Under the 340B drug program, pharmaceutical manufacturers participating in Medicaid and Medicare Part B are required to offer discounts of specified drugs to certain covered entities, usually hospitals that serve as some form of critical or limited access hospital. The program has traditionally worked by allowing hospitals to receive reimbursement at the same rate as other separately payable outpatient drugs, which is generally the average sales price plus 6%, while paying for the drugs at a steep discount negotiated with the pharmaceutical companies. This year, the 340B proposed rules are somewhat a regulatory anomaly due to their current litigation status. The 2020 OPPS proposals for 340B builds on the last 2.5 years of rulemaking and litigation. We're going to briefly summarize these recent key events before outlining this year's 340B comment opportunities, just to give some context for why some of these changes are proposed. In 2017, CMS published the OPPS rule for CY 2018 that cut rates from ASP plus 6% to ASP minus 22.5%, which is a 28.5% reduction, and that significantly cut into hospitals' ability to save under this program and stretch scarce federal resources as the 340B rule was designed to do. These rules were finalized and litigation was filed, but throughout 2018, CMS moved ahead to finalize the continuation of ASP minus 22.5% for 2019, despite an injunction in the district court. The court maintained jurisdiction over the litigation, but mandated CMS to devise its own remedy. As mentioned, these rate reductions remained in effect for 2019. The litigation was amended to include an injunction against this rate as well, and in July, Secretary Azar received a final judgment entered in the district court case relinquishing jurisdiction. Also in July, the OPPS calendar year 2020 proposed rule was released, which proposed to continue the ASP minus 22.5% rate, despite having two years of that same rate enjoined by the district court. That same rule seeks input on a proposed remedy, which we'll discuss shortly. These cases are now consolidated and have been moved to the U.S. Court of Appeals. In the 2020 proposed rule, CMS proposes maintaining an ASP minus 22.5% rate as the 340B repayment rate. Anticipating that CMS may not prevail on appeal, the proposed rule also seeks comments on a suggested remedy. This remedy can either be retrospective, which would be made on a claim-by-claim or possibly a hospital-by-hospital basis for claims paid at that reduced rate. If budget neutrality is found to be a requirement by the appellate court, however, it's important to keep in mind that these reductions have already been spent elsewhere, so CMS will have to find a way to make that work. The other option is a prospective remedy, which would be an upward adjustment to make hospitals whole going forward. And one of those suggested rates that CMS included in the proposed rule, was ASP plus 3%, which is still less than the 6% that other separately payable drugs are reimbursed at. Pending a ruling, the OPPS ASC CY 2021 rule will address what this remedy is. So what's next in the 340B story? The appellate court has issued an order for briefings with oral argument to be scheduled. No extensions are likely to be granted. The agencies and the courts want this case resolved very quickly. The Secretary's brief was submitted on September 3rd. That brief maintained position very consistent with what they said in the district court, which was that CMS has the authority to make this rate reduction, and that any rate reductions or remedies must be budget neutral. The litigation was brought by the American Hospital Association and a group of hospitals, including one in the Adventist system, and their brief is due in response on September 24th. And the final reply brief from Secretary Azar is due on October 11th. We do anticipate this case will be resolved in 2019, so comments on a remedy are very. We are seeking comments from all members that are covered under OPPA, that are part of OPPA. How has this rate reduction impacted you? And do you have any recent stories or specific examples of the negative consequences of the 340B rate reduction? And then finally, and very critically, what remedy do you think would be most appropriate? We have an opportunity to offer CMS creative, informed solutions here, and this is a great opportunity to do that, to try to mitigate some of the impacts that 340B rate reduction has had on our health system. The transition now to changes to the inpatient-only and ambulatory surgical center lists. The IPO and ASC lists represent a transition to less resource-intensive settings. The decision to remove a procedure from the IPO list usually considers safety, quality, and cost. A procedure on the IPO list is only reimbursable if it is performed in an inpatient setting. When something is removed from an IPO list, that means it can be performed either in an inpatient setting or an outpatient setting, depending on criteria usually set by CMS. CMS will also allow some procedures to be performed in ambulatory surgical centers to reduce costs even further. The major change to the inpatient-only list this year is the removal of total hip arthroplasty, or total hip replacement. This means that certain candidates would be eligible to have THA performed in an outpatient setting. CMS is seeking comments on its proposal to remove THA from the IPO list, and they're looking for input on the risks, benefits, and unanticipated outcomes that this might have. We encourage commenters to consider the role that hip replacements, and as we'll discuss shortly, knee replacements play in our bundled payments for care and improvement models. These site of surgery shifts have major impacts on our case mix, even though the target price data may not shift accordingly. So many patients who are part of a healthier population might shift to an outpatient setting, leaving those in an inpatient setting, possibly at a higher cost. CMS also anticipates a need for some standardized criteria to determine which patients are appropriate, and we do seek input from our stakeholders on what that criteria might be. One of the technical changes to the IPO list is introducing a one-year RAC review exemption for procedures removed from the IPO list. So for anything that's removed from the IPO list going forward, there would be a one-year exemption from being referred to a recovery audit contractor, which is usually just making sure that these are billed properly and that there's medical necessity. And the idea behind this is that it would allow for providers to have an adjustment window to the new criteria and these new outpatient options. CMS seeks input as to whether 1 year is appropriate or if a longer or shorter period is more advisable. Relatedly, CMS is proposing 5 different procedures to be reimbursable in the ambulatory surgical center or ASC setting. Of great interest, again, given our participation in the comprehensive joint replacement and DPCI advanced payment models, is this addition of total knee arthroplasty or total knee replacement. As many of you might remember, last year, TKA was removed from the IPO list, which allowed it to be performed in inpatient or outpatient settings. And now we're seeing this expected shift to the ASC list, which is going to allow it to be performed in another site. Research is suggesting that TKA in the ASC setting is fairly quality and safety neutral and generally cost beneficial. The other procedures listed up here are also being added to the ASC list, and we're likely to see more of these types of stent placements and cardiac interventions going forward. CMS does seek comment on the associated risks overall and appropriateness of allowing these procedures to be done in an ASC. They would like to know what criteria would be helpful to determine the appropriateness of a patient to have that procedure there, and of course if there's anything else that they'll consider. It is likely that TKA performed in ASCs will be at a higher cost to the patient, and that is primarily because ASC coinsurance is less than outpatient coinsurance. We would also like to refer you to Table 33, which includes a list of future coronary interventions that CMS is considering adding to the ASC list in coming years. This outpatient shift table is just sort of a nice way to summarize the movement of certain procedures and what to expect going forward. So in the immediate, we know that total hip arthroplasty is being proposed to be removed from the IPO list, and that TKA is proposed to be added to the ASC list for 2020. This leads us to believe, based on the movement of TKA, that we expect something similar for partial hip arthroplasty and similar sort of orthopedic musculoskeletal interventions and cardiac interventions going forward. We encourage you to consider how these might affect any BPCI models that your system participates in, and start to sort of anticipate long-term changes on the case mix. In addition, CMS is proposing changes to its ambulatory surgical center quality reporting. One of the major concerns with ASC procedures is that they aren't necessarily in a good position to capture post-surgical adverse events, which can make outcomes in these settings seem better than they are. For instance, ASCs are unlikely to know whether a patient has to seek follow-up care due to a complication, because that patient is more likely to go to an emergency department that isn't associated with the ASC. CMS does continuously develop and modify quality measurements for ASCs, and this offers more insight and understanding around the risks and benefits of moving to this potentially more cost-effective setting. This year, CMS is proposing the adoption of ASC 19, which they're calling the facility-level 7-day hospital visits after general surgery procedures performed at ASCs. This measure is intended to capture all-cause, unplanned hospital visits that happen within 7 days of any general surgery performed at an ASC. Visits includes an emergency department visit, an observation stay, or an unplanned inpatient admission. So it's a pretty comprehensive measure. It's important to note that this is NQF endorsed, Data collection will start in 2021 for 2 years for proposed payments beginning in calendar year 2024.
In the outpatient space, the Outpatient Quality Reporting Program, or OQR program, is a mandatory program. Hospitals must report relevant claims in order to avoid a 2% penalty. There are not many changes being proposed this year to the OQR program, but we do see a few measures removed as well as some considered additions. CMS is using the updated measure removal factors to audit the measures included in OQR in the upcoming years. Based on these factors, CMS proposes to remove one measure, the external beam radiotherapy, or EBRT measure, from the program under Factor 8. Removal would occur in October of 2020, which would impact calendar year 2022 payment determinations. CMS is really asking for feedback here on potentially adopting 4 safety measures that were previously used by the ASC Quality Reporting Program. Measures ASC 1 through ASC 4 were put on hold on the ASC program a few years ago due to stakeholder concerns around the data submission process. So CMS is seeking comment on including these measures, which would be updated to be for the outpatient setting to the OQR program. It's worth noting that these measures, NQF endorsement was allowed to lapse by the measure steward. Just to clarify that it's not because of a deficiency in the measure itself. There's nothing wrong with the way that it measures. It specifically has to do with the way that CMS had hospitals reporting their data. It was very difficult, or for ambulatory surgical centers. So if adopted, CMS would first fix the data submission, and then they would work with the NQF to have endorsement reinstated.
And now we'll be covering some technical and procedural changes related to the issues outlined on your screen. So for reduction of payments for exempted off-campus providers, as you may all remember, the Balanced Budget Act of 2015 reduced payments for new off-campus provider-based departments that had never billed Medicare prior to November 2nd of 2015 when the law was enacted. Instead of receiving the OPPS payment rate, these provider-based departments would receive the lower physician fee schedule payment rate. In 2019, CMS expanded the site-neutral payment policy to off-campus PBDs that were exempted by the Balanced Budget Act of 2015. So those that were already in existence prior to November 2nd, 2015, would also see payment reductions and be paid under the physician fee schedule instead of the outpatient prospective payment system. This site-neutral payment reduction would only be applicable to clinical office visits provided in the exempted PDDs. In this year's rule, CMS proposes to complete the 60% payment reduction that started in 2019, so that clinical office visits in exempted PBDs are paid at $46 a visit instead of $116.
Another change in the technical area of the OPPS rule for this year are to the drugs, biologicals, and radiopharmaceuticals and the pass-through status. Transitional pass-through status is something that allows supplementation generally through a facility fee increase, while a new drug or an orphan drug sort of develops a market price. So when a new drug gets pass-through status, it's usually paid by Medicare at the wholesale acquisition cost plus 6%, and then as cost and price data becomes available and there's a market established for this drug, it transitions to that ASP plus 6% rate that other separately payable drugs are paid at, and that facility fee increase will eventually go away. So post-expiration, it'll be paid at ASP plus 6% unless it becomes packaged or a 340B drug. Table 14 in the unpublished OPPS rule has a complete list of the drugs that will lose pass-through status this year. It's important to note that these pass-through status is largely a matter of statute, so a 3-year window is as much as any drug usually gets on this list. We still do welcome comments, of course, if there are any specific concerns about the drugs that are losing pass-through status. In addition, CMS is also proposing that 5 procedures be added to the prior authorization list. And prior authorization essentially means that a physician would have to seek CMS's permission that this procedure was medically necessary before guaranteeing reimbursement. And the 5 procedures that they have indicated this year have both cosmetic and therapeutic indications, but CMS has seen high utilization over the past few years that is continuing to increase at a pretty rapid rate. And those 5 procedures are listed on your screen. In addition to this, they are also proposing a provisional affirmation threshold exemption of 90%. And essentially what this means is that on a semi-annual basis, physicians would sort of be audited by CMS, and if they're getting it right 90% of the time, they will be exempt from having to complete these prior authorizations during those time periods. We see comments on whether that 90% is a feasible number for physicians, or if it is too high or too low.
CMS also proposes to downgrade the level of supervision that will be required for some outpatient, or for all outpatient therapeutic services rather. So under their proposal, these therapeutic services would move from needing general supervision, which means that the doctor needs to be immediately available in the facility, so they cannot be with other patients. They have to be either in the room or maybe in an office right next door, to general supervision, which means that while they still need to be supervising, they can rely on some of their, the rest of their clinical team to kind of oversee that procedure. And of course, this would be only in cases where the doctor believes that it is medically appropriate, and if there's a clinical reason, they could absolutely flag it for that higher level of supervision. CMS has already been allowing this on a case-by-case basis. For example, CMS has allowed small rural hospitals to exercise this flexible supervision to enforce or to maximize the use of providers that are scarce in their area. So for example, a radiation oncologist, they could share him between multiple settings, and that would be appropriate. CMS monitored this for a few years, and they see no difference in the quality of care from either beneficiary watching and observation or from polling providers. So they just want to go ahead and make this flexibility available in the outpatient setting for everyone.
CMS is also proposing a couple of changes to the clinical laboratory date of service policies. I will only highlight the 2 most important changes that are proposed in the rule. The first pertains to changes in the test results requirement. So this would be considered a hospital service unless the ordering physician determines that the test does not guide treatment during a hospital outpatient encounter. CMS is also excluding blood banks and blood centers from the laboratory date of service exemption. So the date of service, if this policy is finalized, would be the date that the specimen was collected instead of when the actual test was provided. And this concludes today's webinar. If you have any questions about any of the policies that we discussed today, please feel free to contact us. Thank you for your time, and we appreciate, again, your thoughts and expertise on this issue.